Hey Lisa, how are you? We have a patient who may need an evaluation for advanced lipid management therapies. And he's a 54-year-old male. He got admitted to the CCU post PCI. He had two stents, proximal to mid LAD with 90% stenosis, and he's got a newly reduced EF. On his medical history, he's got high blood pressure, he's on medication, it's well controlled, he's got prediabetes, he's got hyperlipidemia, and he's overweight. On the family history, he's got a premature CAD. His father had an MI at age 53. He also reports that he has been on pravastatin for 2 years and on a high statin therapy, 80 milligrams. And he reports before to that prior to that he was on pitavastatin, and all of a sudden his insurance stopped covering it. But amidst all that, he's been taking his medications regular and as prescribed. His lipid profile, though, before the high statin therapy, his cholesterol was 239, triglyceride at 109, and HDL 58, and LDL at 159, VLDL 22, his cholesterol to HDL ratio 4.1. Although we may need further testing for his lipid, I don't have any lipoprotein A or A and B studies. He's a non smoker, drinks socially, denies any use of recreational drugs, is limited on his physical activity, reports some sport related injuries and issues with his lower extremities.
Hey, Jonathan, thanks for calling. I'm so glad you called about this patient. He sounds like a great patient that needs some discussion as far as what we can do to get his cholesterol, especially his LDL, as low as possible. So, since he's had a recent lipid panel, but then started an increase to high intensity statin therapy, I think we need to talk about repeating that first and going from there. The other ideas I have is to make sure or to see if he would tolerate a cholesterol absorption inhibitor and then probably recheck lipids after that. But definitely with his recent history of CAD, his recent MI, and PCI to the LAD, I agree that we want to drive his LDL as low as possible.
Thanks, Lisa. Yesterday we had a great, family conference, and we discussed goals for his recovery. In particular, we talked about the primary and secondary prevention opportunities he has. We discussed in particular lowering his LDL as one of the priorities, and he may need further evaluation, as I mentioned, and on the advanced lipid management. But both patient and the family were receptive to that. And I have provided them some, patient education materials and resources on the lipid management. And he did express some concerns about, given the history of insurance stopping his coverage on the statin therapy, he was wondering if he would qualify for the PCSK9 inhibitors.
Yeah, let's talk about how we could get that medication approved because sometimes, honestly, that's the hardest part. So, once a PCSK9 inhibitor is ordered, what happens in my clinic is it goes immediately to a pharmacist. Once that pharmacist can look at that, they can dive into the patient's direct insurance plan and use that to determine what we may need further, what's missing, what we might need to do next. So sometimes it's readily approved. It's easily approved. That's all we have to do is just put the order in. Other times I found that it may be as simple as repeating a lipid panel, or sometimes it takes me changing and documenting something a little bit differently. Um, Other times I found that we may need to track his lipids to see if we can show that there hasn't either been an improvement on his current therapy or that it's not just quite enough. Other things I found with insurance, and I look for three major things, are three of the following. One would be a family history of heterozygous familial hypercholesterolemia. Second would be diagnosis of homozygous familial hypercholesterolemia. And that third thing would be that established cardiovascular disease, which is where this gentleman falls in. So he's had that recent PCI, so he would be a perfect candidate to look into getting insurance to approve this. Now, the other thing that we can look at, which we wouldn't have to, is a fourth thing if he would have primary hypercholesterolemia, but not any of those other conditions as above. But again, we've already established that he has cardiovascular disease. The other thing that we'll want to document in his note would be that he's tried and had an adequate response to that high intensity statin therapy. Another thing would be we definitely want to document that he hasn't tolerated one of the statins or maybe had a statin intolerance in the past. The other thing would be if there would be any FDA contraindication to him taking a statin, which it doesn't sound like that would be the case. And we also want to document that other than the statin and the newly approved PCSK9 inhibitors, those would be our main forms of therapy. And we're not using an additional PCSK9 with that. Lastly, we want to make sure that since he's being referred to cardiology, we'll take care of prescribing that. So it needs to be prescribed, or it's recommended to be prescribed by cardiology or endocrinology.
This is great. This is great guidance. It looks like he might be a suitable candidate for the PCSK9 inhibitor. So, one of his care goals includes that he needs to achieve confidence in kind of managing his self-care, monitoring at home, and regular follow-up. This therapy seems to be promising, but I'm concerned if he would agree to self-administered injectable therapy.
You're right, Jonathan. Sometimes that's the hardest part is because a PCSK9 inhibitor is an injectable therapy, it seems scary, especially to a lot of patients. What I like to do, at least on that visit when we talk about that, is demonstrate and show him the options. I really like the SureClick system. That's an easy way for patients to be able to see and use that therapy in practice. The other option we have, if he would feel more comfortable, we can definitely bring him in and have him administer that clinic or that injection in the clinic where we're right there to say, hey, let's try it this way next time, or how did that feel? What can we do better? So that's an option too.
Well, that's wonderful, Lisa. I'm comfortable because now that he'll be able to kind of see what it looks like, or even do that in front of you and your team. I'm confident that you'll be able to uh, you know be willing to accept this therapy. Um, I have a few questions though. What barriers do you anticipate, and what recommendations could you provide that would better prepare him as we navigate this?
On some insurances, we've had trouble getting the PCSK9 inhibitor approved, even though they have the correct diagnosis of ASCVD or coronary disease, like our patient. Sometimes that's because the LDL they want lower than, or they don't want lower than 100 or even 70. One of the other frustrating things can be that the approval at the 12-month mark of that PCSK9 inhibitor. And with this, sometimes they want us to show that the patient has actually had success in using the PCSK9 inhibitor and that the total cholesterol and LDL are lower. Whereas other times they want us to start from the beginning and do that paperwork again. A lot of the times it's just going through the motions and jumping through those hoops. But don't worry, we'll work through that with the patient and we'll get it approved.
Oh, this is much better. Oh, thank you so much, Lisa. I'm glad I made this call. I can have enough guidance to get him started with the care transition, and I'll provide him, all the resources that we have, and for the follow-up care.
You bet, Jonathan. Thanks so much. I love when we as team members can collaborate and do what's best for the patient and find the best possible solution. this is one example of many of the patients that could benefit from a PCSK9 inhibitor.
You're right, Lisa. Now, what I'll do now is I'll place the referral to your clinic. I will copy the attending and the PCP, the primary care physician, and I'll provide him your contact details and the directions to your clinic. He has my number, and if he needs anything from me, I'll be happy to assist him as he needs. Thanks, Lisa. Bye.